Okay.
All right. So good evening, afternoon. Thank you for joining us. For those of you that don't know me, I'm Vicki Lowe, Executive Director for the American Indian Health Commission. I am Statithlam New Sklyam, Jamestown Sklallam, Bella Coola First Nations, Nuksak, and I've worked with in the Indian Healthcare Delivery System since 1996. And we have, I'm just going to go as I see you, Ashley. You want to introduce yourself?
I'm Ashley Lothanes. I am the Legislative Administrator for the American Indian Health Commission. I'm also Jamestown S'Klallam descendant and Bella Coola First Nations. Welcome.
Thank you. Heather?
Hi, I am Heather Holzer. I am also a Jamestown Scholar descendant and Bella Coola First Nations. And I'm a consultant with the American Indian Health Commission, focusing primarily on communications and public relations.
That's why we're actually having this presentation tonight. And then Amber, you already introduced yourself, but do you want to just say it one more time? She might be driving. Amber is the Tribal Policy Director at the Department of Health. And she's Nisqually, and I know that you have other relations. Okay. How about Maria?
Good evening. My name is Maria Ness. I am the Legislative Liaison for the American Indian Health Commission. I'm really glad to be with you today.
Thank you. And we have our onboard notes in here, which is type of AI. It's part of our system that we use to track all our meetings and notes and stuff. We use it just for the purpose of taking notes. So if there's questions and things we need to follow up on. And I think, Heather, is the plan to share this with people if they request it, the recording?
Yeah, yes. And I'm working out the details of where we store the recording, whether it's an onboard or a YouTube video or uploaded as YouTube. But we'll share it out with anybody who wants to rewatch or wasn't able to join us.
Okay. Emily, do you want to introduce yourself?
Sure. Good afternoon. I'm Emily Main, and I am the tribal liaison for the western side of Washington, and so I'm one of the two tribal liaisons for the Washington State Patrol. Thank you for having me.
Thank you. And coincidentally enough, Don Poland was the former Washington State Tribal Liaison, Washington State Patrol Tribal Liaison. Hi, Don.
I am driving, so I'm multitasking, hands-free. My name's Dawn Pullen. I'm a Spokane tribal citizen, and I used to be with the Washington State Patrol as their tribal liaison. Now I'm over at the Washington State Recreation Conservation Office, and I'm the Tribal Affairs Director. And so I describe RCO as think of salmon. Sorry, somebody just pulled out in front of me. Salmon, whales, and trails. And so our expertise is grant administration. Glad to be here. Thanks, Vicki.
Oh, nice. Thanks for being here, Dawn. And Rebecca Purser. Good afternoon.
Good afternoon, everyone. Rebecca Purser, Suquamish, here representing the Office of Native Education within the Office of Superintendent of Public Instruction. I have the honor and privilege of an initiative to support our tribal schools with opioid and fentanyl prevention work. And so I'm really grateful to be in this space with you all. Thank you.
Thank you. Thanks for being here. Amanda?
Hi, good afternoon. My name is Amanda White Crane. I'm the Director of Tribal Services at Volunteers of America, Western Washington. I support both the Native Resource Hub and the Native and Strong Lifeline, which will soon include chat and text, along with the 988 option 4.
Thank you. That's exciting. How about Amanda Gorman? Where'd you go?
Hi.
Hello.
Yeah, I'm here. Amanda Gorman-Body. I'm the Director of Tribal Affairs for Molina Healthcare Washington. Happy to be here. Look forward to looking in. Thank you.
Thank you. And Teresa Hattori.
Hi, everyone. I'm Teresa Hattori. I am the Tribal Affairs Administrator for Community Health Plan of Washington. Thank you for allowing me to be in this space.
Thanks for being here, Teresa. Chanel.
Haslahel, Chanel Squally Jansen, Teedsta, Puyallup Upspuds. Good day. My name is Chanel Squally Jansen, Puyallup Tribal member, and I'm with the Department of Children, Youth, and Families in the Office of Tribal Relations, and I'm the Tribal Prevention Service Specialist. So thanks for having me.
Thanks for being here. And Zipporah, is that correct? Fuller?
Yeah. Can you guys hear me okay?
Mm-hmm.
Okay, perfect. Hi, everybody. My name is Zipporah Fuller. I am the Health Director here at Cowlitz Indian Tribe HHS. Thanks for having me.
Thanks for being here. Okay, I'll bring the slides back up. Was that everybody? Did I miss anybody? Okay. So for those of you that aren't familiar with the American Indian Health Commission, we are a commission for the tribes. So we work on behalf of the 29 federally recognized tribes, the 2 urban Indian health programs, and Indian healthcare providers here in Washington State. We were founded in 1994, part of some of the Centennial Accord work. We were definitely called out in the Millennial Agreement as one of the organizations for the state of Washington to work with on behalf of the tribes. I've been around the commission almost my entire career, but started working more closely in 2012 and became executive director in 2015. And as part of after we got things kind of under control, our executive committee wanted us to have a presence in Olympia, which I live in Sequim, so I didn't want to because I love it up here. So we started working on finding ways to use legislation to address some of the issues that we were having in barriers to healthcare for American Indians, Alaska Natives, and Washington State. So this is our 7th year of doing legislation. And so I just want to thank you for joining us and giving us the opportunity to share what we're working on for 2025. And this is a Ask Me Anything. So if you do have questions, feel free, raise your hand or just unmute and ask them. I'll go through our priorities and then also give another opportunity we can talk about things. There's other things that are emerging and becoming issues that if we have time, we can talk about as well. But our 3 big priorities this year are a bill for bringing traditional Indian medicine in reimbursement into the Medicaid program, an Indigenous data protection bill that's a part of a really large body of work we've been doing since COVID, and then tribal foundational public health services funding. So the first bill has already been introduced, and tomorrow it is having its first hearing in the House Health Committee, and it's House Bill 1583, and it directs the Healthcare Authority to apply for a CMS waivers, Centers for Medicare and Medicaid Services, to approve traditional Indian medicine as part of the Medicaid program. This is something that our tribal leaders in the urban programs have been asking about for many years. In 2012, we tried to do a waiver for unreimbursed cost and tried to include traditional medicine in there, and that wasn't very successful. We've tried to think of other ways to do this, but CMS in the last year or so put out guidance about how to do this waiver. So part of how it works in Washington State is that the legislature actually has to give give the healthcare authority the authority to apply for this waiver. So we have to go through our legislature. There are 4 other states that have been approved for traditional Indian medicine waivers, which makes us really hopeful. And those are Oregon, California, Arizona, and New Mexico. And Utah is really close. And, you know, in all honesty, with all the upheaval at the federal level, we don't know what this means for us, but we really want to move forward with this effort. The Seattle Indian Health Board has been working under a grant from the Healthcare Authority for the past couple of years, developing billing codes for traditional Indian medicine. And because we are going to make sure this provider is part of the Indian healthcare delivery system, they'll be considered an Indian healthcare provider, and tribes and urban programs will be able to get their encounter rates. The tribes is the all-inclusive encounter rate, and then the 2 urban programs have their cost-based encounter rate as an FQHC. So the state is worried about budget impacts from implementing this waiver. I think you might all be aware, because most of you have some kind of connection to the state government, this is a really rough year for asking for any budget items. We've asked the Healthcare Authority not to put a fiscal note on this, because we feel like this work is a regular part of the work they do, and they should have enough staff now to do this without asking for more staff or money for staff. I think the big issue they're worried about, because of the success of all the opioid treatment programs and how they've seen non-natives, they think that there might be a lot of non-natives getting traditional Indian medicine, and that they will have to pay the state share of the encounter rates for those, which is kind of a complicated problem. But I don't know how many non-natives will be getting traditional Indian medicine, and how tribes would even feel about providing those, maybe to family members. So the bill just basically directs the Healthcare Authority to submit the 1115 waiver while working with both the tribes and the urban Indian health programs on the application. So stopping there and seeing if there's any questions, comments. I'm very excited about this bill. Like I said, it's been like 13 years, even more in the making, but really in my work time, it's this last 13 years we've been trying to get this moving. All right. And then our second bill that is introduced, and did I get the right bill number on there? And yes, it's, and I don't know that it has a hearing scheduled yet, but we're very hopeful, because our good friend and one of our favorite legislators, Representative Chris Stearns, is the vice chair of the committee. It'll be heard in the state government committee. And so this one, as I said, came out of a larger body of work we've been doing since COVID, that was really around data in, well, at the time, the Department of Health system. But we know that there's a lot of tribal data in all of the state systems, you know, and the Attorney General's office has been working on missing and murdered Indigenous women and persons data. And they're doing the boarding school report, which for now, because of the Public Records Act in Washington State, they actually aren't writing things down or recording people's information, because they know that if there was a public records request, they would have to release it. So this bill is not as broad as it sounds on this slide, but it exempts specific data that is held in state agency data systems from the Public Disclosure Act. So then if that data, because of tribal data sovereignty, is actually owned by tribes, and if someone wanted to approach tribe and ask them about their data, that's where that conversation should have. But even though this data is held in the state systems, the story that needs to be told with it needs to be told by the tribes and the urban programs. So any comments on that or questions? And this one, I think, like the traditional Indian medicine bill, I don't think we'll have any problems getting it through. This one, we probably get a pushback from what's called Allied News, and there's also a committee that supports the Public Records Act called the Sunshine Committee. So we'll probably hear from them, but we've done, I think, a pretty good job talking to legislators across the aisle. And, I think the tribes have done a good job teaching their legislators about tribal sovereignty, and a lot of them were like, tribal sovereignty, tribal data sovereignty makes sense to me. So we're hoping this one will go through pretty easily too. And then this is not a bill, but it's part of the budget process. The Department of Health submitted a decision package as part of their budget that came from the Foundational Public Health Services Steering Committee. And if you're not familiar, a Foundational Public Health Services, it's been around for almost a decade now, Maria, right? 2015. But there have been different times in the last, I don't know, 50 years where public health has been funded and then funding was taken back. In 2012, there was some legislation that caused the funding to be undone. I think that was the time when we were paying with our tabs for our car, and it was some of it was subsidized out of there. So this was an effort of bringing together the different partners in public health in Washington state and figuring out what were these services that needed to be provided to all Washingtonians, including American Indians and Alaska Natives, in order to help make our population healthier and keep us safe. So when Secretary John Weisman was still at the helm of DOH, he really worked hard to get the tribes at the table because he understood that our people and the tribes and the urban programs, we don't get funding for public health, any dedicated funding, and that, the public health services that were being provided and still are at tribes are woefully underfunded. And that also that he had a good understanding that tribes really knew how to do public health in a way that we don't call public health, more that being, taking care of your community. And I think there's lots of different words. I know there's some different Salish words for that. So in 2018, it took a little bit of time, but the American Indian Health Commission, our delegates voted to have us start attending the Foundational Public Health Services Steering Committee meetings and start figuring out how the tribes could be a part of the Foundational Public Health System. In 2019, the Washington State Legislature passed the Foundational Public Health Services Act, which named the partners in the governmental public health system in Washington State, which included tribes and tribal programs, as well as Department of Health, the State Board of Health, and the local health jurisdictions. And when that happened, it enabled funding for tribes as one of the partners in the system. And back in those days, there wasn't a lot of money coming from the legislature. This was pre-COVID, and we were really fighting to get $12 million for the whole system. And so COVID happened, and the legislature started really paying better attention to public health. We saw some big increases in funding. In 2022, the tribes started contracting with the state for these foundational public health services funds. And it's only been $200,000 per year per tribe, and then $75,000 per year for the urban programs, because they're not governments, so they play a part, but they didn't have all the governmental duties. Which is good for like building infrastructure, and tribes have been working on like community health assessments and building codes and hiring public health staff, making position descriptions and program outlines. And so at this time, and in agreement with the other partners in the steering committee, the tribes have really asked to increase that amount to 10% of the overall funding. The $200,000 per year was only 3.58% of overall funding. So if you have 4 partners and one of them is getting less than 4% of the funds, and that's the partner that has the, the highest health disparities, I think everybody could really understand why this increase was important. So the increase also included for the rest of the partners looking at the increase in providing these services and, having staff and retaining them by increasing wages. And so there's an overall increase for the system. And then of that, we're asking that there's a 10% set aside for the tribes for FPHS funds. So this will get them over, double what they were receiving in the past. And we feel like this is very important as we continue to do this work. And then, this connects to the data sovereignty work when tribes getting access to data in state systems, that they can get positive communicable disease tests results. They can get information about the health of their own population and start to help make decisions about how to improve their programs to address specific needs. So this one's a pretty important one. Before COVID, it was really hard to get tribal leaders to focus on public health, but I think having gone through COVID and really, seeing the impacts it had, not just on the health of people, but, it had financial impacts and all kinds of things. So it's really important to make sure that we're keeping this funding up, even when there's not something obviously going on, even though there is bird flu out there. To make sure that the funding continues. And I think one of the things that we've talked to legislators about, because these funds are that general state funds that are impacted by the revenues, and trying to look at better ways to have dedicated funding for foundational public health services. So we'll continue to have those conversations, but for now, this is the ask for this legislative session. Any questions? All right. And then we have some other priorities that aren't really like our bills or things that we worked on, but we're actually this first one kind of is. But we are also making sure that the legislature knows that these are important to us. There will be a proviso in the budget, but a no cost. So we feel like it'll go through. Extending the Washington Tribal Opioid and Fentanyl Task Force through June 2026. This was part of last year's slate of bills to address the opioid and fentanyl crisis. The task force was stood up. We've really struggled getting our committees in place. Then there's this big change in the administration. So just really struggling with that. So we're asking for another year with the same funding we already have. The state budget doesn't usually carry over funding from the old biennium to the new biennium, but we're asking them to do that this time because the money's been already allocated. And then I think I saw Michelle Wade, Gladstone Wade from Commerce, and just a call out to the Commerce budget for a 10% tribal set aside in the Housing Trust Fund. And we've been making sure that the legislators know that this is very important too. We like that 10% set aside because it goes along with the National Indian Health Board resolution from 2022 that asked the federal agencies to set aside 10% of their funding for different grants and make sure that they got funded to tribes to really start to address those health disparities that are really disparate. But that hasn't happened. So we've been really working at the state level, trying to get our state government to think about that, and have been way more successful here. Thanks, Michelle. I don't know if you want to add anything, but we're just very excited about even it might be a smaller amount than it started out, it's still something, you know.
I can add a few details just so that we're all on the same page. So we submitted within the Housing Trust Fund and we actually asked for a dollar amount up front. We asked for a 60 million set aside for a tribal track. And we also asked for one FTE in our housing division that would be 100% dedicated to working with the tribes on all issues around housing. And then, of course, would be involved in the housing subcommittee, Vicky, that we're working on under the task force. So it did make it into the Inslee budget at a reduced amount of 25 million instead of the 60. And we have not heard about the fate of the FTE, if you will. But we're hoping that the set aside will make it, and that I have been told, I'm not lobbying now, just for the record, that tribes have their lobbyists out there pushing this forward as well. And that even if we don't get the FTE, the work will continue. My office will just figure it out.
Thank you, Michelle.
Yep, absolutely.
And that is very connected to the opioid and fentanyl task force work, and definitely something we talk about every time we meet. So thank you. And then a couple of other bills that have numbers and are moving. There's House Bill 1203 or Senate Bill 5183. They're companions. And this one removes flavors from tobacco products. You know, especially the vaping products are really targeted at our youth, other youth too, but our youth. And we've actually heard reports from some of the tribes that they're finding fentanyl in the flavored vape products on the black market. So really just wanting to get rid of those and try and keep kids from smoking as long as possible. So if they do start smoking, they have a better chance of quitting, but hoping that they never get to where they smoke. And this can have huge impacts, especially with the fentanyl in it. So both those bills are moving. There's some resistance, but you know, and it hasn't passed in the last couple of years when a similar bill was introduced, but I think we're really hopeful this time. And then the last two companion bills are House Bill 1262 and Senate Bill 5228, and it's changing some of the makeup of the Governor's Health Disparities Council, which is basically from the agencies, their staff from the agencies that are part of the council. In the past, the Governor's Office of Indian Affairs has had a seat, and when Craig Bill was the executive director, he handed that seat over to the American Indian Health Commission because he thought we were better suited to be on that council. So over the years, Steve Kutz, who's our chair, and Jan Marie Ward, one of our consultants, have sat on that council. But when we heard that they were opening up the bill, the RCW, to change the makeup, we thought it was time that the council actually got real tribal representation. So this part of the bill is adding actual tribal representation to this council, and we think it will really help with the work that they do. And so that's our short version of what we're working on. Here's our contact information. And then I'm going to stop sharing and open it up for questions or comments. If there's bills you want to share with us that you think we should know about for your agencies, or that you think might impact our tribal health programs, we're really interested in hearing about them. I do have some other Medicaid stuff to talk about, but I don't know who all. Maybe Teresa, you might be interested in that. And Amanda White Crane, there's no other bills for the 988 for Native and Strong this year, right? I know that they talked about increasing the fee there's a bill to increase the fee to bring more funds into the 988 system, but I hadn't seen any other bills.
Yeah, I'm not aware of any. I think just a lot of the discussion with 988 has been around co-location, really some co-response funding. And yeah, don't have anything specific to our line other than the chat and text.
Which is very exciting. Yeah. So some of the other things that we're working on kind of behind the scenes are more like budgetary and Medicaid fee for service. If in the the federal law requires a lot of things of American Indians, Alaska Natives when they receive health care through the Indian healthcare delivery system. One of them is if you are referred for care outside of a tribal clinic, so using the Purchase and Referred Care Program, that you're required to sign up for any other benefits that you're eligible for and use them. And the one that gets used the most is Medicaid. Another federal rule is that if you're American Indian Alaska Native, that you are exempt from being put into managed care. And we've really pushed that forward in this state and worked very closely with the former governor's office and with the healthcare authority to make sure that they abide by those rules. When the Affordable Care Act happened and there was the Washington Health Plan Finder was built, we actually got to help build the application to make sure that it exempted American Indians, Alaska Natives from managed care, and which means they end up in the fee-for-service program unless they choose to enroll, because for us, that is actually informed consent. And nothing against managed care, but a lot of the things that the managed care programs do are things that our tribal clinics are also doing with our patients. We already have a referral process. And so if you're on managed care, you have to go through the managed care referral process and then your tribe's own referral process. And it seems really unfair for people. But the states really moved forward with managed care and kind of left the fee-for-service program behind. So one of the things I'm working on with several of our legislators is really getting them to include fee-for-service when they're making legislation about the managed care organizations. So there's a bill that's being worked on that's about the reprocurement of managed care organizations and behavioral health organizations. And behavioral health organizations are also a form of managed care. And so we've been working on how do we include the Indian healthcare providers appropriately in this, and then how do we include the fee-for-service program? So you'll probably see more on that. There won't be a lot of, we're going to testify for things or anything. It's just kind of going on in the background, and then we're working with the legislative staff on making sure those changes happen. So that is one thing that's pretty big deal. And I've been talking to the legislators for both the House Health Committee and the Senate Health Committee for, I don't know, probably the last 7 years, Maria, about how they've really abandoned the fee-for-service program, and how when we have our tribal members in fee-for-service, that's fine when they come to our clinics, but when they go to be referred out for healthcare, there are no specialty providers because the payments are so poor. And so, used to be if you filled out an application to be a provider for Medicaid, you were taking both a managed care and fee-for-service patients, but that doesn't happen anymore. And we're questioning why and when that changed, but it really impacts the ability of our tribes to refer people to specialty care. And then because of the loophole of being able to change from managed care to fee-for-service, sometimes the tribes will just put somebody in managed care till they can get their specialty care and then opt them back out, which isn't really good or fair to the managed care organizations. So we're just really trying to make this system, the healthcare system, be more responsive to our people. Same with behavioral health organizations. They have gotten all of the funding for behavioral health crisis. When we passed the Indian Behavioral Health Act in 2020, we added and Indian healthcare providers with community behavioral health programs to who's eligible to receive funding. And tribes, have begun having their own tribal designated crisis responders and really building up their crisis programs. So we're seeing, case rates for different things, but not really having us considered in the budget the way that the other parts of the system are. So that's something else we're working on. Yes, thanks, Emily, for posting that.
Sure. May I comment?
Oh, absolutely.
Are you familiar with the substance use prevention statewide program that Kitsap Public Health was partnering with Kitsap County Prevention Services, Clallam and Jefferson County were in partnership too. I could send you some more resources if you're curious. It was a statewide prevention program that was unleashed last year, and I'm forgetting the name of it. And I just looked at the Kitsap Public Health website and did not see it, so I'm not quite sure what the status is there.
I think I've seen it, but yes, please send it so we can make sure
I can do that.
it's shared out. Yeah.
Thank you.
Is that the Flavor Hooks Kids one?
Yeah.
Is that what it's called? Flavors Hook Kids?
I was thinking.
No, I should. It's at the tip of my tongue, so I'll try to do a little more research while on the call and send that information to everyone.
Okay. Thank you. Anybody else with questions or with other legislative priorities, either from your agencies or your tribe that you know about?
Vicki, this is Rebecca. We have out of the Office of Native Education, we have a one-pager of the bills that our office is following. And so I will send that to you, just forward it to you if you want to share with folks.
Yeah.
I want to say we're following very closely at least three, and then the other ones, just that monitoring and then the overall analysis. The one that we are super excited about is Senate Bill 5570. Kaufman is the lead sponsor, and this is in regards to tribal sovereignty and elevating the JMLSTI curriculum and ensuring that there is accountability and implementation practices in place. And so, fingers
John
crossed.
McCoy since time immemorial.
Yeah, it's John McCoy, Lola Leash, since time immemorial curriculum.
That's awesome.
Mm-hmm.
Does it include funding to tribes for developing, their curriculum?
Yes. So we currently have a grant available for our state tribal education compact schools as well as our tribal governments. And that grant is available through our EGMS grant system. And anyone is more than welcome to reach out to our office for any technical assistance when it comes to EGMS because it is a complex system to navigate. But yeah, that provides funding to, and then they also have a similar grant that is provided to public school districts as well. There is one requirement, and that is consultation and collaboration with the tribes within their boundaries of their school. So,
yeah. But the money goes to the school, and can the school contract with the tribe to help develop the curriculum? I think I
yes.
Okay.
Yes. So the public school district side grant, the school district handles the funds and then works collaboratively with the tribe. And I'm not sure if they go into contract with them, but I wouldn't be shocked if they did, just to utilize funds and then also compensate the tribes for their commitment to ensuring that it is the curriculum that is most relevant to where the school district is located.
Thank you. Anybody else have something to share? I'm going to put our slides in the chat. Sorry. Oh, Friends for Life. Thank you, Emily. If we get done early, I have to go to a city council meeting, so let's keep talking. Just kidding. Any other agency request legislation you want to share? Do have one more thing to tell you about that's really convoluted, so. The other priority we're working on is also part of the Medicaid program, and it has a 25-year-old story. So the short of it is for since 1996, tribes, when they see American Indian, Alaska Native, the Indian Health Services facilities and the tribal facilities, when they see American Indian, Alaska Native enrolled in Medicaid, the federal government pays 100% of the claim. So it's called 100% FMAP. And when tribes under self-determination started their own substance use disorder programs, I think everybody thought they would only see American Indians, Alaska Natives. And so the state was, like, good, because that'll be paid 100% by the federal government and we won't have to pay any of it. And that's how they figured their budgets. But a lot of these programs were really successful, and, tribes have more than tribal members living on their reservation. They have, family members, they have employees and other people that they serve, and many started serving non-natives. And at the time, the behavioral health wasn't integrated. And so substance use disorder was separate from mental health, that was separate from dental, and was separate from physical health. And so just for substance use disorder, the state told the tribes they couldn't afford to pay the state match on the non-natives. So when a tribe sees a native, it's paid at 100% of the federal match. When they see a non-native, the federal match is only for whatever percentage any other enrollee would get. I know this is why I said it was convoluted. So at the time, the state match was mostly 50%. So the state said, we're going to pay you 50% of your encounter rate, and then, well, we're going to pay you the full encounter rate, and you have to pay us back half of it because we can't afford it. So this has been going on for years. When the Affordable Care Act happened, it continued. When they integrated Medicaid with the behavioral health, substance use disorder, mental health, it still happened. So for all the other visits that are medical, dental to non-natives, a tribal clinic gets paid the full encounter rate, but for SUD, they have never been paid the full encounter rate. Well, there's guidance that came out in 1998, so before this happened, from it was so old that it was the Healthcare Finance Administration who existed before CMS. And they said, well, we have this one facility, one rate rule. So if a patient is seen at a tribal clinic and they have Medicaid, you can't pay different rates for them. And the same goes like a federally qualified health center. So, but that hadn't happened for the SUD payments until recently. CMS started questioning the healthcare authority, who now has the payments for these services, about why they weren't following the one facility, one rate rule, and told them they had to start following that. So because we've had so many very successful opioid treatment programs, and a lot of them are seeing like a high percentage of non-native, some of them, I think Jamestown and Digital Lake both say 80% non-natives, 20% native, which is great because when you think about public health and treating the whole community, that's how you heal people. But this has become a budget problem because of this, the revenue forecasts and the budget deficit that is, I think it's different every time I hear it, but I think last time I heard it was a $12 billion deficit over the next 4 years. And so the Healthcare Authority did a decision package on the state share. Instead of budgeting it, which should be part of their budget, they separated it out and called it a tribal non-native SUD encounter payment and asked for $70 million, which is a big ask in this budget. So we are working behind the scenes to make sure that that doesn't get thought of as a tribal issue. It's not. Worried that it might not get funded because it's such a big ask, which leaves the tribes and the healthcare authority in the same situation where the healthcare authority is violating this federal law, and the tribes are still eating the state share of the encounter rate. So I hope everybody followed that. And if you didn't, feel free to ask questions because, like I said, it's a 25-year-old story and it's really convoluted.
This is Rebecca. I have all kinds of questions, but only because I haven't been a part of the 25 years, and so I'll leave all of those aside. This one is more specific to the work that I've partnered with Lucy to present to our state tribal education compact schools when it comes to Medicaid. And so every time I heard one of those buzzwords, I was like, yes, this is the type of information that will bring the puzzle pieces together when it comes to that presentation around schools accessing those funds to provide more services, but through Medicaid.
Yep.
So
Yeah. I'm happy to come to a meeting, and because I've lived through the whole 25 years plus of all this stuff. But yeah, and there's like the four walls rule where tribes became tribal FQHCs in the Medicaid program, so their providers can practice outside of the four walls of the tribal clinic, because before they couldn't receive the encounter rate if they provided outside. So they can actually go to the schools now and provide care and get reimbursed.
Okay. I just love that. I learned so much from all of you. I'm so grateful to be in this space with you all. And it's set for February 12th, right after the monthly tribal meeting. I believe it's 3:15 or 3:30. But I can forward you the invite. You're more than welcome to come and join.
Yeah,
if your schedule allows. Yeah, of course.
Yes. Hello, Leah. Thanks for joining us.
Sorry for being late.
It's okay.
I'll do dishes.
So I'll probably do them for you again. That's a little joke. My office used to be in the kitchen. My husband likes to just come in and do dishes while I'm on a call.
At least he's doing them. It's okay.
Yes, that's true. Very well trained. Do you have anything from OIP that you wanted to share as far as legislative priorities? I know we get a big list of bills every week from Tim, but I think you're just tracking all of them, right?
Much as we can, yeah.
It's a lot. I just heard today in a meeting earlier that there have already been 1,200 bills introduced, and I think that's how many were introduced all of last session. So it's a little crazy.
And I thought I heard today at a meeting earlier that Department of Health has already reviewed like 300 plus bills. I'm like, holy smokes.
Yeah. And that's the thing about the tribal staff at each of the agencies. They have to look at all the bills and think about the tribal implications too. So that's a big part of your jobs right now, huh?
Yeah. So anytime you get a list together, go ahead and send it to us and we'll send it out with ours. Because I think Tim does it every Friday.
Yeah.
Sends it out. So.
Okay. Thank you.
And we're not lobbying.
Nope.
For the record.
Was the
And
governor?
I was
Yeah.
with you. The day that I was with you guys at Ledge Day, I had put in a leave slip. I was there on my own time.
We call it educating, Leah. We educate them every year.
And there
Remedial training the year after.
But there were a lot of new legislators this year for Ledge Day. So that was interesting and great because many of them were really receptive to what we were talking to them about. Like I said, across the aisle, explaining foundational public health services over and over again is a lot. But, I just think we have really good legislature this year too. And they're really grappling with not only the budget, but also what's going on at the federal level and how that could impact things. So, yeah.
Interestingly enough, and what Vicky is saying, one of the things that I think we recognize as we were talking to the legislators this year is that even our colleagues on the Republican side had full understanding of tribal sovereignty. They had no question about the right of the tribes to own their own reports. I know that sounds their own data. I know that sounds funny, but in past years, it's been a real hard thing for them to grasp. So it's been moving more and more towards that understanding and what it means in real practice. So they're coming along pretty good.
I've been practicing my sitting still and waiting for somebody else to talk, but I'm not very good at it. I get that from my mother. All right. I put those slides in the chat box if you want to grab them. I think we might also send them out. There's a recording if once we get it figured out, it'll probably be YouTube, I think, Heather, that we can share too. But I just want to thank you all. I really appreciate you coming and hearing what we're working on and sharing what you're working on. And just in that spirit of working together, I love what you said, Rebecca. It's like you can hear little bits and pieces and you're like, wait a minute, I think that has something to do with something I'm working on. So I really appreciate the spirit of working together that we all have.
Yes, it is incredible. Because we know all the puzzle pieces are there. It's just making those connections to connect. And I think we're really, really close to, an entire puzzle. It's been incredible to witness the growth in our state when it comes to the states supporting tribes and our governments and our overall systems in a more reciprocal way. I think that's something that I have really cherished witnessing is the reciprocity that's been happening since I joined. It's just it feels good every time I'm in these spaces.
Yes, thank you. And thank you for joining because I've seen huge changes in our work with OSPI since you've been there too. It's not the connection to health is really important. I see that happening and that's great.
Yes, you're welcome. I'm really grateful that I have been able to, uh, navigate an agency where we don't always talk to one another. And so to bring in other folks and strengthen OSPI's presence in these spaces has been quite a journey, but I'm really grateful for the ones that are as committed as you all. And, the executive leadership has just heard nothing but wonderful things from the communities. And so they're really grateful that we were able to connect and continue this work together because that's just what we do.
Yeah, thank you. Oh, and Chanel, I saw announcement for the train the trainer for the Indian positive Indian parenting program. I sent it out to our delegates too. So thank you. We appreciate that the tribal leaders really called that out in 2023 at the Centennial Court as a resource that was underutilized. So it's good to see that getting out there.
Yeah, so that's one of the things that I'm working on here is bringing, we have 3 positive Indian parenting classes. 2 are virtual, 1 is in person. The 2 virtual filled up super fast and we had a large wait list. The second one already is getting a huge wait list and I really wish we could offer more, but the budget now, that's not something I could do, but we are presenting that to expand it statewide and offer more trainings next year. And so that's our hope is that we can offer more of those trainings. And I think the in-person one in May is, I believe after today, I just went and looked at just a few minutes ago and I was like, I think the in-person one might be full now too. But I want to keep the wait list going because the first one, there was a lot of cancellations. And so then we would pull people in from the wait list. So,
okay. Yeah. So tell people don't give up.
Yeah, exactly.
Yeah. Great. But it's also sad that you don't have money to do more. Amanda, yes, aren't you guys doing something too?
Yes, it's been slow getting off the ground. We are still, unfortunately, I dropped in the chat hiring for the family resource specialist that would offer telehealth and positive Indian parenting groups. So please help us get the word out. We're still in the process of doing interviews, and that would offer, yeah, some virtual groups and touch bases, and we're really excited to start getting referrals once we're all operational.
Thank you.
Yeah, and Amanda, she's working with us at DCYF. We have 10 pilot tribes that are offering different services throughout Washington. And whether it's positive Indian parenting or healing of the canoe or other services, tribes get to pick their own services, very flexible for whatever they want to do in their community. I know Tulalip is doing a positive Indian parenting that's geared specifically towards grandparents raising teens, which is something that they saw a huge need for in their community. And so that's all really exciting too. Another thing that we're doing really quick, since we're talking about all this, is within those pilots, the UW social work program we're partnering with, they got some money from Balmer organization to provide capacity building evaluations. So approaching the pilots and being like, hey, is this program that you're doing something that you're interested in evaluating? How would you like to do that? Is that, and speaking of the data sovereignty stuff, that's a huge part of it. They keep their data, they share with DCYF what they want. In each pilot, gets to choose. Sorry, I saw your face and I got a little distracted. I was like, oh, what did I say?
Oh, that they keep the data.
That the tribes?
No, that does the institute keep the data or the
No,
tribe?
the tribes.
Oh, the tribes.
The tribes keep their own data. Yeah. And they can share what they want. But it's really about building, if they want to do an evaluation on whatever they're working on, it's UW coming in and helping however they want. However the tribes want. Sorry, not UW helping. Okay. UW gets to do whatever they want. No, it's very flexible and open to however the tribes want to do it. And if they want to do it, it's all voluntary. They also get these mini grants for doing it and getting participation from any participants. And anyway, yeah.
That's wonderful. Yeah, so one of the projects we're working on that isn't legislation but is related to FPHS is that we're working to build a tribal and American Indian Alaska Native PRAMS, which is pregnancy risk assessment, measurement, surveillance. I don't know. Anyways, it's a survey that the state does that when we look at the questions, we're like, Native people aren't going to answer those questions, And so we're building a survey that really is more appropriate, ask questions that hopefully get answers, but also that looks at the root causes. I know a lot of times when I see state surveys, nothing against the state, but I just sometimes their questions feel really blamey, you know, like, you know, what was the behavior that caused you to do this? Not really understanding that, you know, we have to deal with trauma and deal with healing. So we're very excited about that, and it should be ready to be administered at by the end of June. And then also same thing with the data the data will be housed with a third party. And we're looking at how tribes can be able to, thank you, Heather, how tribes can be able to access their data once the surveys are complete. But really looking at how we can work on the system, because when I feel like those blamey questions sometimes deal with how the systems don't want to take accountability for how difficult it is for people to utilize programs that were built without thinking about our culture or our ways. And so I'm very excited about that. Monitoring, pregnancy risk assessment monitoring system. Thank you.
I like the word surveillance in there better.
Yeah, surveillance is scary. What a way to not get people to fill out a survey.
Especially nowadays. Jeez. So I have a question that's like kind of on topic, but not really. So those of you guys know my son's story. So he's actually looking for work to be like a resource. He wants to go into the community and like meet them where they're at because he understands that. But what I've learned, and I've gone with him a couple times, is there's different names to these type of positions. It's like,
Yeah.
why can't they just be like a streamlined, like, because they're not. And they make these big fancy names. Like, how do you know to look for that in a job, you know, in a job search? It's very interesting. That's so frustrating.
So I'm on the Joint Legislative Committee on Behavioral Health or something like that. And it's really like a report to the legislature, really looking at behavioral health services across the state. And that's one of the things that's really come up is, why do you have all these different position descriptions? You know, why do we make it so hard for people?
Yeah.
You should make it like, it's very streamlined and, you know, education wise, I think peer specialists are really great. I know there've been some problems with people getting certified. And then I think it wasn't until recently that they got reimbursed for their services. So can't really make a job of it. When I met with Representative Lauren Davis about our traditional Indian medicine bill, she asked about a possibility of having a peer support position. Now, this won't help your son, but that is a tribal elder. And so I think she might be working on that. Maybe, I don't know if it's going to happen this year, maybe next year, but you're right. It's very, I think my word of the day is convoluted. It's too many different positions and just not enough focus on paying the people to provide services. It's all about jumping through hoops and getting certified for different things. And
I know. Or it's like just have it be something that's simple. Because I know he went to they live down the street from St. Vincent's in Tacoma. Because he went over there and it just happened to be where they didn't have somebody that did that, like available position. But it was a girl there that said, hey, go to multi-care, but it's called this, this, and that when you look it up. And it's like, what? I think it was at Greater Lakes or something here in Lakewood. But it's like, why can't it just be something just
easy.
Google it and find it as a navigator resource. I don't know what else you can call it, but he's looking. That's what he wants to do.
Yeah,
it's just.
That's amazing, Leah.
Yeah, I think he'll do well with that.
Yeah.
Yeah.
On top of all this work of trying to find where there's help getting, because he's got to get dental work done because of the drug use so that's been really interesting too. It's like there's nothing out there to help those that are in recovery for their dental, but at least he's able to use IHS. At least he'll get some dentures, but he's so excited about that.
Yeah. Oh no,
I'm
I
gonna
know.
have my smile back. That's his big. He's so excited.
That's one of the big wraparound services at the MAC clinics is dental care, because people are like, it makes it like saying, look, I had an addiction problem. And, when people see your mouth and then when you have your teeth fixed, then that's not the first thing people see.
I know that was something that when I told him, I said, hey, I'm in a lot of groups that want to hear your story and they want to hear it from you. And he just says, Mom, what people don't realize is when you're talking, everybody looks in your mouth. He goes, and I'm real self-conscious of that. And I'm like, you're right. Like, I didn't think about it, but I'm like, no, you're right. So maybe once he gets his mouth in and he's going to look good again, then he'll be more willing to share story besides me sharing with everybody.
Well, proud mama.
Yeah.
Nothing wrong
Proud
with that.
mama.
I am. He's a good kid.
Yeah.
We really enjoyed having him at our summit last year. It was
I'm
great that he
hoping-
was able to come.
Yeah, I'm hoping that if we can, because we had to put in a request to be allowed to come to the one in May.
Oh, that's right.
We're able to, and if he's not working, I want to bring him.
Cool.
Vicky can help you with that.
Well, I know Tim was asking about that. Like it'd be probably just Tim and I coming. Probably all of OIP can't come, but because of our budget cuts, they're like. But Tim knows, he understands the importance of us going. So
that's good.
Yeah. So I know we had to put in an ask for that.
Yeah, that's another tough thing that makes it hard for the tribal liaisons to do their job right now, is you can't travel to the tribes, which is like an important part of the work.
I know. And that's what I keep saying,
Yeah, we're holding our meeting, our quarterly delegates meeting at DOH to make sure that tribal agency staff can come, but then there was some kind of problem with the Office of Tribal Affairs. We got it fixed. They're coming now.
So that's the one that's happening Wednesday?
Yeah.
So I was thinking about coming in person, but then I heard that that's like a day where a lot of people are choosing not to work and there's gonna be protests. And I thought, I don't know if I want to be, I've been stuck in protests before when I've been in the office. I'm like,
that's a good
I
point.
think I'm just going to attend virtually.
The protests are supposed to be at the Capitol, so.
Yes.
What are the protests for?
It's going to be for us.
I'm sorry, what?
Oh, go ahead.
No, go ahead.
No, what I heard, it was just going to be like a day where a lot of Mexicans are just not going to work and see what the workload really is like without having our people there. So it's going to be interesting. Because I'm also Mexican.
Yeah,
along with
me
being
too.
natives. It's going to be very interesting. My girls are very much about not going to work that day. So we'll see.
Yeah, no.
Sorry,
that reminds
Vicky,
me.
I can't come to the meeting on Wednesday.
Hey, wait a minute. Me first.
That's right.
I'll be at Maria's house.
Me first. Okay.
Organizer.
Making tamales.
Yeah, you girls can come over and eat tamales here. There's if you ladies have not seen, if you ladies have not seen, there's a show, a movie out there called A Day Without Mexicans. Pull it up. It's funny, but it's based on reality. What would happen if all the maids, all the gardeners, all the, people that work everywhere, if they just went away? The people that pick our food and put it in, on our table. What would we do as a United States of America? But you should look at it. It's a good show. It's a good education.
What's it called?
A Day Without Mexicans.
Okay, I'll look it up.
Easy peasy. Sarah. Call me if you forget.
All right. I think we're getting into dangerous territory. Maybe for some state staff. I don't know. I know, Leah, you'll be fine.
They're used to it.
All right. Well, thank you everybody for joining us. Last call for.
Actually, it's after 5, so I'm good. I'm on my own time. It's after 5.
Okay. We do appreciate you taking a day off work and coming to the legislature with us. So.
Of course. No, I was all about that. It was good. I loved all that. It's really just, it's nice. It's nice stuff, the work that you guys do.
Thank you. I appreciate the support.
All righty.
All right. Thanks, everybody. Have a great evening. I think you'll get the slides if you didn't grab them
Thank
out of the
you.
chat. Thanks for
Thank,
sharing.
thank you for all the great information.